Hello, thank you for the very nice introduction, Francesco, and hello to everyone. So I hope that the presentation that I will make today will be of interest for the audience. As you said before, I am a hematologist. I'm from Italy. I worked for many years and I trained myself in Milan at the Istituto Nazionale Tumori. And in the last 5 years, I moved to Barcelona. So currently, I'm dealing with allogeneic stem cell transplantation and the CAR T cell therapies. And apart, and my interests are lymphoma, and I am a clinic. I mean, my interest in research is generally clinical, but it is true that during the last 4 to 5 years, I started to work with people and investigation group, which were more focused on using AI technologies in analyzing clinical data, and also with engineers we've had more experience in creating a telemedicine platform, and that was true especially before the COVID pandemic. So today, I'm happy to present you some work and where we are in the setting, in this very specific setting of use of AI for prognostic scores in allogeneic stem cell transplantation, and the works that we did with telemedicine platform in these very specific fields. These are my conflict of interests. And this is a summary of the talk that I want to talk today. So in the first part of the talk, we are going to discuss about the use of artificial intelligence used to improve the prediction of the survival outcomes of a patient who received in hematopoietic stem cell transplantations. And we will revise a few papers, seminal papers related to this topic. And the second part of the talk, we will discuss not just about artificial intelligence in this setting, but about the use of newer technologies, namely telemedicine, in the setting of the follow-up of such patient after a transplant or CAR T cell therapy. So in this setting, we will briefly review which are where telemedicine can improve the setting, the clinical setting for such patients, and also a little bit of history of telemedicine, and finally the studies that we did in our group and in general in hematology. And finally, we will do a brief summary and of course a Q&A session with all of you. So I know that your group is working a lot about the application of AI in the oncology setting. So recently, in the last, I'd say 2 to 3 years, also the use of AI has arrived also to the clinicians. So in generally, I think that I personally think that oncology maybe has come years later in comparison to other specialties such as radiology or cardiology about use of AI algorithms in the clinical setting. But now we have arrived. Of course, I'm not talking about the use of AI to interpret the results and the big data generated by omics technology, but I'm referring about the use of AI in the clinical setting, so which is quite new in the setting of hematology or oncology. So of course, in oncology, AI has already been used in all the setting of the computer vision analysis. Of course, in oncology, we are using a lot of radiology data deriving by, for example, magnetic resonance or a CT scan or a PET scan in the setting of hematology, for example, for lymphomas. This is what we are using. But it has been used also by the pharmaceutical companies for finding newer molecules, newer structures, molecular structures, and for save time basically to find more effective molecules and losing more time and less money to do that. And of course, AI has been used also to interpret large amounts of clinical data in this setting, apart from biological data. And also, as you can observe in this review, which is very useful, and I suggest you to read if you have time, for the interpretation also of the physical activity data of the patient. In this setting, all the data deriving from wearable devices. Of course, I mean, maybe this slide is useless for this audience, but AI can be used in the clinical setting of oncology and hematology, especially for a transplanted patient or a CAR T-cell patient. The use that we have done with AI until now, it has been used to create prognostic scores. In fact, before the advent of AI, and still for a majority of the physician in these very specific fields, what we are using for our patient are prognostic scores, which have been derived by the use of standard statistics computation, such as logistic regression analysis, basically. But in the last, I'd say, 10 years, 9 to 10 years, the first studies which have tried to improve the prediction of these outcomes using AI-derived algorithms have been published. So the first type of these studies that we will review later have been based on decision tree analysis algorithm. But then lately, more advanced algorithm using deep learning or Bayesian-derived statistics also have been used to do that. So um, basically, the first study which have been published back in 2015, trying to use a machine learning derived prognostic score, was made in the setting of the European Bone Marrow Registry, which is the biggest European association collecting data from all the European countries, basically, of the patient who received stem cell allogenic transplantation. So in this study, which was led by the PI of the study, which is Ronnie Cheval, currently working at Memorial Sloan Kettering in New York, they analyzed almost 30,000 adult patients receiving a hematopoietic stem cell transplantation affected by acute leukemia, both myeloid or lymphoid acute leukemia. And in this setting, when we are performing an allogeneic stem cell transplantation from the clinical point of view, what we are basically do in our clinical practice is evaluate candidate patients for these procedures. So you should know that this procedure is still characterized by a high toxicity. So basically, in general, we have from 15 to 20% of patient candidate to such procedure, which will die not because of the tumor, but because of the toxicity related to the treatment. So for example, they could die because of infection, or they could die because of immunological complication, or they could die because of organ failure, for example, cardiac insufficiency or respiratory insufficiency, renal insufficiency. So it is very important, extremely important to exclude patient for which we know before performing these procedures that they have a too elevated risk of dying because of the procedures. So as I was telling you before, we are using, and there are different scores which have been created using logistic regression analysis. And the most common score, it is called Hematopoietic Cell Transplant Comorbidity Index, which the problem with this comorbidity index is that the accuracy level or the area under the curve of such scores that we are using in the real life population is only about 0.55 or in other studies 0.60. So the accuracy is very low. So this is why we are trying to improve the interpretation of such data in our clinical practice. So in this study that I was presenting you before, this has been the first study trying to improve such results. They used 40,000 patients from a European registry, and the primary objective of the study was to predict the overall mortality at 3 months after the stem cell transplantation. But also in the secondary objective, of course, it was the estimation of this non-relapse mortality, which is the probability of dying not because of the relapse of the disease, but because of the toxicity, which basically is the toxicity related to the transplant. So in this setting, this investigator used as an algorithm, a machine learning based alternating decision-free algorithm, which was classically applied for on 70% of the data and validated on the 30% of the data. And here on the right, you can see the variables, which the clinical variables, which were used to develop the algorithm. So these are very specific variables, which basically are related to the characteristic of the disease, the characteristic of the patient, basically the age of the patient and the clinical status, the fitness of the patient, and also variables related to the transplant, like the intensity of the chemotherapy that we are using for that patient, the type of donor, for example, matched related donor, unrelated donor, or haploidentical donor, which is basically is the son or daughter of the patient, and also the year when the transplant was performed. So here you can observe the model of the alternating decision tree on the right to predict the overall mortality after 3 months from the transplant. So about the interpretation of this model, I'd like to skip that. This is very specific and very technical data. But basically on the right, you can see how the clinic, as from the clinical point of view, the type of prediction that with this score can be done for a patient, it has improved. So the first thing that the authors allowed to do with this article, it was to allow all the physician evaluating patient for a transplant to evaluate and generate a personalized risk score of overall survival for the patient which were evaluated for transplant, and also the area under the curve in comparison to the comorbidity score, which is the most commonly used prognostic risk model, has been improved. So the area under the curve for this new model was over 0.70, while for the comorbidity score it was between 0.6 or 0.65. In fact, starting from that first study recently this year, this is one of our last papers that we've published last year. It is a study which was trying to improve the prognostic and the accuracy capacity of the scores that we are using to evaluate the toxicity of the patient. So in this case, we did this analysis with the epidemiological and statistical unit of our department. In this case, we also got the patient from the European registry. In this case, we evaluated and we generated this model from more than 30,000 patients. In this case, oncological diseases were different and heterogeneous. It was not only acute leukemias, but also we include lymphomas and multiple myelomas. And in some way, we selected as primary objective of the study the same objective which was evaluated by Ronnie Chuval in the previous study that we showed before. So the primary endpoint was the overall mortality at 1 year. And also, of course, we're trying to predict no-relapse mortality at the same time point. The model was trained on 70% of the population, optimized on 15%, and validated using 50% of the data set. And instead of using just one machine learning based algorithm, we of course we perform an analysis with the logistic regression analysis to compare the results to this standard methodology. And we also applied other 6 AI algorithms. 5 of them were basically standard machine learning algorithm, while the last one it was using a neural network type of algorithm. And as you can observe here, actually we improved our accuracy and the prediction accuracy of our algorithm when it comes to evaluate the overall mortality of the patient. The best algorithm that we use for overall mortality was a gradient boosting, and also that one developed with a neural network analysis. But still, the area under the curve to predict overall mortality was just 0.64. So we improved a little bit, our capacity prediction, but in general, these are results which are not considered good. And also, the same algorithm was tested also in a very specific subpopulation, which were the patient using an haploidentical donor, which is donor compatible just 50% to the patient. And also in this setting, results were good, but not as good as to change our clinical practice. So basically, the results of our study show that yes, maybe we can improve the algorithm that we are using to predict and interpret this clinical data, but if the data that we are using, in this case, which were related, and we retrieved them from the European Bone Marrow Transplantation Registry, didn't add any predictive analysis. So I mean, the results finally are not improving. So AI, of course, it is a more powerful strategy for a prognostic score, but it's not magic if the data that we are using are not good or not significant. And finally, we also demonstrated that we can generate like personalized risk score also with our prognostic scores. But finally, the capacity of the area under the curve and the capacity of the score are not as good as we expected. So maybe the idea is that we should first find a newer and a better biological or clinical prognostic factors which are able to predict better our patient. And also maybe we just selected a risk factor which were available before transplant, but maybe as the zoo in this last analysis, which has been recently published this year in Blood Advances, the name of the journal. In this case, the authors they created another risk prognostic score using a machine learning algorithm, but in this case they also used a longitudinal risk factor. So they add to the model, they added also some factor which basically consisted in events which could happen after the transplant. So you know that after allogeneic transplantation, a patient could get many complications, and of course, if you are developing one of these complications, the chances to die because of the toxicity could get higher. And so it is important to have a model which could include also longitudinal measurements or events. So in this setting, these authors trying to do this, they include about 1,000 patients. So the number was inferior to the other two studies that I presented. But using a Bayesian-derived algorithms, they showed that actually the capacity of the algorithm to predict the outcome of this patient was higher than the previous two studies. So basically, you can observe here how the area under the curve, the capacity of this score was almost 0.9, which we have never observed in the risk score for allogenic transplant. So maybe the future will be, yes, to utilize machine learning derived algorithms, but also to introduce better biological and clinical risk factors, and also not just characteristics which are present before the transplant, but also but also after, so longitudinal events. And with this, I would say that relating to the use of AI as to predict the survival outcomes for allogeneic transplantation, we don't have any news in our field. It is true that now there is a cell therapy, CAR T cell therapy, which is the most recent therapy that we are using for lymphoma patients. And in this setting, it is true that there are different groups that are trying to use such scores and developing AI-based scores also to predict the outcomes of this new therapy. So we will see if in that field we will get more precise score, and of course that everyone can use. Because the other point is that you are developing such a score in your institution, but then also the feasibility and applicability of such score in the clinical context it should be something easier. Otherwise, all this improvement which will never get to the real life and the clinical setting. So the second point that we tried to develop in my institution, trying not just to improve the prediction of the patient who receive an allogeneic transplantation, but it has been also to improve the follow-up of the patient who receive an allogeneic transplantation. And so that's why we try to focus on telemedicine. We were not thinking and we were not using any telemedicine tool before the COVID pandemic, but after the pandemic, of course, it was clear how trying to avoid unnecessary visit to our patient, maintaining a good and safe clinical follow-up for our patient should be of paramount importance to avoid infection of our patient. And also, when the COVID-19 pandemic passed, we also discovered that our patient actually really liked this type of telemedicine follow-up because it was also more comfortable. They feel that were safer and so on. We will see later which were the results of this study. So basically, telemedicine is a very large field of interest in medicine. It has already been used in many specialties, especially in cardiology, I'd say, where they first started to use this telemedicine connection to for the remote monitoring of such patient. And basically, telemedicine enables the physician or the healthcare providers to deliver medical care, consultation, and diagnosis. Maybe treatment. I'd say that telemedicine still is not, apart from very exceptions, we are not using it to deliver treatments for the patient, in oncology at least, or in hematology, but for a diagnosis and follow-up, yeah, we can already use it right now. And there are different type of telemedicine. So it could be a real time or it could be postponed visit. And maybe where we can where is the field of telemedicine? Maybe it is at the intersection between a large field of the digital health and the precision medicine. You know that now that precision medicine in oncology is something that during the last 10 years, I would say it's a term that it has been used to define this rule of for each patient has a very specific tumor and each patient has a very specific characteristic. So precision medicine right now it has only used especially for the analysis of the tumor, but more recently, also because of the more importance that we are giving and attributing to the quality of life of the patient, we are also using precision medicine to adapt the therapy and the follow-up that we are giving to our patient. So maybe telemedicine is in between digital health and precision medicine. And of course, telemedicine could also involve the use of and it is generating big data, especially for if you're using wearable devices. And the analysis of such data could be used and interpreted using AI application. Also, AI can be used in the form of natural language programming algorithm also to contact the patient. And since the visit with our patient are basically based on the language and the words and communication, more recently, telemedicine is also incorporating natural language programming software and algorithms. So just a brief history of telemedicine. Of course, telemedicine roots are going back to when the first communication tools have been developed. I'm referring to the phone. And it is true that the history of telemedicine is strictly related to the U.S. Army is beginning. Actually, telemedicine started being used by the U.S. Army in the Korean War during the 50s and the 60s, and then more recently during the 90s with the advent of the internet, it has been possible also not just to connect with patients or a doctor, but also to transmit data, in this case images or a refutation of, for example, a pathology report. And today, with the evolution of telecommunication and science, the role of telemedicine and its means, it has evolved a lot. So it has been applied not just to the cities and urban hospital, but academical center, but also to the most rural and province centers. As I was telling you before, telemedicine is a very general term, but basically we can classify telemedicine in a three type of service. So the first one, it is called a store and forward telemedicine. So as the name is saying, store and forward telemedicine consists the transmission of general medical data, okay, which could be war file or imaging, to one location to another, and these data are interpreted and reviewed by healthcare personnel lately. So in this case, it is not a contemporary synchronous telemedicine service, okay? And we can refer to this service, for example, when you think about a radiologist who is reviewing, for example, it's a chest X-ray or a CT scan data or magnetic resonance data. Then we have a second type of telemedicine. This is called real-time telemedicine. This is referring to live video conferencing or even without the video. So basically calling your patient between the patient and the healthcare provider. And you can imagine real-time telemedicine as the classical medical visit where there is a virtual connection between a patient and a physician. And finally, we have this third type of telemedicine, which is called the remote patient monitoring. So in this setting, the difference between the real-time telemedicine and the remote patient monitoring is that both modalities are representing a synchronous type of telemedicine where data are interpreted or communication is in real time. But in the remote patient monitoring, there is not a direct communication between the patient and the healthcare provider. So the healthcare provider is receiving data from a patient, and it can of course interpreting them in real time. And this, for example, could be while a patient are using some medical devices, wearable devices like watches or medical patches, and there is an healthcare provider interpreting this data there. But a direct connection with the patient is not possible. So we have, I think that after the COVID pandemic, we have realized, of course, here in the hospital setting about the potential advantages of the use of telemedicine. So in this case, especially in our public healthcare systems, where the problem of money is fundamental. So in this case, using of telemedicine, first of all, from the patient perspective, you can see that telemedicine has allowed a large amount of the population to have a better access to healthcare. Imagine, for example, patients who are living the mountains or on some islands with just a very reduced number of population. So basically, patients without the healthcare structures. So in this setting, healthcare could provide a professional monitoring of a more critical patient, and in that sense, in the case if this is necessary, translate the patient to other centers. The second point is that telemedicine, it has been shown in a lot of articles and papers and reports and public healthcare reports that is cost effective. So why telemedicine it is cost effective? Because we are, I think, we are used to a classical model of the medical visits where the patient and the healthcare provider should be stay and being in person during the visit. But this is not the future. I think that the future of healthcare, in some cases, is already the present, depending on the visit that our patient has to perform. But the visit could not be in person. So there is not, we don't have always the need of performing in-person visits. And also in some cases, hospitalization is not necessary if we can allow the patient to being better monitored at the domiciliary setting. And also telemedicine can be used to perform a triage of the patient, so avoid unnecessary admittance to the emergency room, for example. And finally, it has been shown that also telemedicine can improve the patient outcomes. Why it can improve the patient outcomes? Because, for example, if telemedicine can perform a real-time and continuous monitoring of patients, for example, affected by chronic diseases. Imagine, for example, progresses that have been made in this field with patients with glycemia, glucose control, and monitoring for patients with diabetes. And also it has been used and it has been shown for cardiology, for example, for the control of arrhythmia patient and behavioral health treatment. So we can use different technologies in medicine, in telemedicine. Of course, this can be used to do in video conferencing or telephone, for example, for the visits with the patient. And I would say that during the COVID pandemic, a lot of papers were talking about telemedicine, but then when you read the paper, basically this telemedicine consists in a phone call. So we are now 2024, and the phone call maybe is less. It's for a type of communication for performing a more complete visit with telemedicine. We also have remote monitoring devices. Think about a Fitbit or Samsung devices or a Withings, a smartwatch. So we have now also the Aura Ring. Now it's, I mean, it's fashionable. So there are also ring which can monitor the vital signs of a person. For example, cardiac frequency, oxygen saturation, temperature of the body of the patient, and also in some case the blood pressure. And we are still working on the use of devices which could collect without the need of a laboratory the biochemical data. So in this sense, we have, for example, for glycemia, for the glucose level in the blood of the patient, there are many devices that are doing that, but not for other type of biochemical data. And then also telemedicine consists of a collection of electronic health records and mobile health apps. I'd say that there is that the market is full of these mobile health apps, but we are still in a situation, especially in Europe, where the laws are not have not cleared the scenario and when an app could be certified as a medical device. While for the FDA in the US, I would say that they are like 2 or 3 years in advance comparison to Europe, and they also clarify the criteria for an app to be considered a medical device, and also for the wearable devices as well. So going back to my job, so in the clinic, in hematology, and in the setting of allogeneic stem cell transplantation, what have been done? So we have a case study. The first case study that I'd like to introduce you here, it was a system which my colleagues from the Memorial Sloan Kettering developed before the pandemic, the COVID-19 pandemic. So in this case, they created a video conferencing system to perform a real-time visit with the patient. So the patient in that case was accompanied by a nurse, and the nurse was performing the medical visit, and the patient and nurse were connecting with the healthcare providers. So in this sense, they analyzed 20 patients with autologous stem cell transplantation and 5 patients who received allogeneic stem cell transplantation. And this platform was used for the patient or the moment during the inpatient visit, so when the patient was still at the hospital. And the majority of the visit were used when the patient had been discharged, so when he was at home. So basically, this was just a pilot study. So what they did, the investigators here were evaluated the quality of the system in terms of how it was appreciated by the patient and by the doctor. So in this case, you can see from table 1 and table 2 that in general, the patient were more satisfied with the platform than the clinicians. So the clinician still had that feeling that such platform was not able to convey all the information, the clinical information that they need to get from the visit. But when it comes to the patient experience with the telemedicine visits, I'd say that I mean the number of patients at just 25 was not enough to understand to understand completely such evaluation, but you'll see that it was not a problem for the patient to perform a visit by telemedicine, but I'd say that here the population of the study was comprised between 65 to 75 years old of patients. So you should also consider this technological barrier in such platform. So when we arrived during the COVID-19 era, the use of telemedicine expanded also in hematology. So we have some different study worldwide, especially from Europe and United States, where telemedicine has been used basically to reduce the need of in-person visit for the hematological patient and so reduce the risk of getting the COVID. And this has been used for both chronic and acute condition. And I'd say that a lot of those studies were just pilot studies, so with a low number of population, and also the platform was very different, the type of telemedicine that had been used. In this setting from Palandri, which is working in a hematological center here in Italy, I think in Turin, and which have been published just after the COVID pandemic in 2021. So in this case, these authors analyzed almost 500 hematological visits, so not patient, but number of visits, for a patient affected by chronic condition like plaquetopenia or other myeloproliferative diseases. So in this sense, I mean, the majority of such visits were which had to be in person were converted to telephone appointments successfully, and also the patient which were not able to transform their visit in telemedicine visits were patient affected by more aggressive diseases, of course, like this MF is myelofibrosis, which is considered an aggressive and more symptomatic disease. Patients who were receiving active therapy, so maybe which patients that are developing more clinical complication, it's difficult to use the telemedicine platform, or patient enrolled into clinical trial, so which were needing more analysis, analytical tests and visits. And here there is a brief review of how the authors report and describe the switch and the difference between telephone, telemedicine visit and in-person visits. Also, my group from this hospital, during the COVID pandemic, we performed and we created our telemedicine platform. This was just a pilot study. Actually, we started using it in April 2020, and we use it just for the first wave of COVID, which here in Spain last until the end of May 2020. So in this pilot study, we enrolled 21 patients who were receiving autologous or allogeneic stem cell transplantation. And in this case, we develop a mobile phone app, the platform, a telehealth platform, and we educated the patient to collect their vital signs such as cardiac frequency, blood pressure, and saturation, and insert directly the data into this app. So it was not an automated system. And as you can observe from here, only 12 of the 21 patients were able to use such a platform. And this, the reason why the other patient didn't manage to use the study was because of a technical and a technological problem. Especially these patients were older than the other ones and were not practical with the use of a mobile app. And but for the patient who finally managed to use the app, the results and the adherence to the study was considered good, and high report rate was used. And so when we asked those patients who finally were able to use the app about their overall grade of satisfaction, in general they were satisfied. They didn't perceive that that not performing in-person visit was reducing the quality of the medical visit. So in this sense, with this data, we decided to try to improve our platform. And since in our study, basically 50% of the patients were not able to use the app to report the data, we introduced the use of wearable devices to automatize all this system of reporting the clinical vital signs of our patient to the platform. So here is where we added the use of wearable devices in our platform. In this case, we use a smart watch by Withings, a French company which is selling the smartwatch, which is called a ScanWatch. And why we choose a ScanWatch over the other smartwatch? Because it is considered a medical devices to collect clinical signs, clinical vital signs. And apart from that, we also use the thermometers of the same company, which also these passed medical devices approval from the FDA in the US and from the EMA here in Europe. So wearable devices, basically, of course, I have already been used in different settings of medicine. Actually, this year in the New England Journal of Medicine, 4 or 5 reviews have been dedicated to the use of wearable devices in setting of endocrinology diseases such as diabetes, in neurology diseases such as the epilepsy or psychiatry and depression, and of course cardiology, which were the first. So basically wearable devices extend and improve the monitoring that we can perform to our patient, especially for those who require a continuous monitoring. So in the last paper that we published in 2024, this year, basically we tried to enroll about 20 patients. Finally, only 11 patients were able to be finally included in the study and were fulfilling the inclusion and exclusion criteria. Also in this setting, we use this newer and improved platform for patients who received autologous or allogeneic transplantation, and also in this setting, patient receiving CAR T-cell therapy. And we use this newer platform from the first day of the patient admitted at the hospital up to 3 months since the first day of the study enrollment. And this was able basically the data that we collect were cardiac frequency, temperature, blood oxygen saturation, and also the activity, physical activity of the patient in terms of steps, daily steps, and also the quality of the sleep quality. And this is a resume of the platform that we use for the studies. Is our platform that we have here at our institution. So basically, we have this e-connected platform, which for the healthcare provider consists of a web page where all the data of all the patients are collected and uploaded, and where we can follow the data. We are not just collecting clinical vital signs of the patient, but also are collecting symptoms. Symptoms are actively collected by the patient thanks to an app for the mobile. And then clinical vital signs are collected by a scan watch, and the temperature collected by the thermometer. And so to do that, we had our dedicated healthcare team, which was composed by 2 nurses and 2 doctors. And also in this study, the study was a pilot study, so basically it was performed to see how it works. We didn't avoid the patient to perform the standard clinical visit that they deserve, of course. And the results of our study basically were that a majority of the patient appreciate this system. Of the 11 patients, we had 3 cases where the use of such technology was able to predict or to alert or to send us an early alert of a complication, in this case fever, infection, which is the most common complication for this patient. And so we could connect the patient on time and avoid possibly other complications. So for the future, we are trying to improve the system. So in this sense, using even more advanced technologies in terms of wearable devices. And the other things that we'd like to do in the future would be to use a natural language programming algorithms for the detection of symptoms. For example, collaborate with these companies who are using algorithms to contact indirectly the patient with an artificial voice and collect and basically doing an interview to the patient. So this probably would augment also the grade of automatization of the system and the platform. And if we can collect enough number of patients for the study, of course, we would like to use AI-based algorithms and analysis to perform a study and an analysis of the clinical vital signs and symptoms of the patient to predict and to select the patient which are at a higher risk of developing complication after the discharge. So in conclusion, I'd say that for we have seen today artificial intelligence made prognostic scores in the setting of hematopoietic stem cell transplantation and CAR T cell therapy do have the potential to improve the prediction capacity for such patient. However, we should think about finding and improving also the quality and the type of data that we are using to calculate for such patient. And now AI algorithm can allow us also to incorporate, for example, longitudinal data or more complex data such as biological data to such scores. And what about telemedicine? So we proved that also in our very specific setting, telemedicine can improve the follow-up that we are doing for transplanted or cell therapy hematological patient. Of course, there are some drawbacks of telemedicine. For example, I don't know how it is in the Italian institution right now, but for example, here in Spain, of course, this telemedicine visit should be approved by many bureaucratic level and administrative level. And apart from having that legal issues, but necessary, but of course, it's kind of issues that cost a lot of time and money to be resolved. Also from a technical point of view, it is necessary to having not just a clinical team, but a very good engineer team to develop such platform. So maybe in the future, yes, we will have access also in the public healthcare system to a better telemedicine platform. But for current time, it is still related to an area of investigation, which we will hope to improve in the next years. So with this, I'd like to thank you all for the invitation to your very interesting society and association in Italy, and I'm open for questions. Thank you.